All right, here we are again, back for more. This is going to be the first half of the lecture or so for the elbow, wrist, and hand. So last week we did the shoulder, and now we're going to be continuing down the upper body, down the upper limb to the elbow, wrist, and hand. As always, you can be following along with the notes. So let's just start there. All right. This region, elbow, let's talk about the elbow first. What color should I use today? I kind of feel like green. I don't know why. Green is the sage color, so let's do green. The elbow, for each joint, we've been talking about what does it rely on most for stability. If we think back to the shoulder, it has pretty weak bony stability, so it makes it less stable, but we get more motion out of it. So because of its weak bony stability, the shoulder, the glenohumeral joint, it has so ligaments. So for the shoulder, we rely most on muscles, the rotator cuff. For the elbow, we actually rely about half on the bony structure. It has a reasonably strong bony structure. And we rely on the other half on the ligaments. So these are definitely going to be questions that you'll see on the exam. What does each joint rely on most for stability? For the elbow, it's about half and half. Half bony structure, half ligaments. And then when we get down to the wrist, it's definitely one of the more complex joints of the body, so we'll talk about that. But we're going to start with the elbow. So you're going to see a similar structure as what we saw in the shoulder. We're going to start with the bony anatomy, identifying each joint, what type of joint it is, what motions are possible, and in many cases what the closed packed position is, where there's most bone-on-bone contact and therefore is the most stable. So for the elbow, as you can see there, it is the humero-ulnar joint. And just like before, we're identifying the two bones that form this joint, humerus and ulna, humero-ulnar joint. We are going to be more specific. We were for the shoulder, didn't we call it the glenohumeral joint? Because it was a joint between the glenoid cavity and the head of the humerus. So here, for the humero-ulnar joint, I would also like you to know the specific articulating surfaces. So what we see is the articulating surfaces are the trochlea of the humerus. These absolutely should ring a bell from your anatomy class. Just took a drink there, pardon me. The trochlea of the humerus, when I teach anatomy, so at the distal end, when I teach anatomy, it kind of reminds me of a bow tie in shape or a spool. Maybe I'm aging myself here, but a spool is what thread comes on in like Joanne Fabrics or something. So the trochlea has thicker edges and a more narrow middle. So that whole area is called the trochlea. I think of a spool or kind of a bow tie where it's thicker on the ends and a little bit narrower in the middle. So the humero-ulnar joint, more specifically, is the articulating surfaces of the trochlea of the humerus and the trochlear notch of the ulna. You can see that they kind of made it a little bit easier on us. That it's the trochlea and the trochlear notch. They're named because they fit together. The trochlear notch, when I talk about the ulna, right? So the ulna is this bone. Here's the ulna. I'm going to do a really bad drawing, okay? The ulna is kind of flat, narrower on one end, but then at the other end, it forms like what I call an ice cream scoop. It's kind of hard to see on this picture, but the trochlear notch is the actual ice cream scoop. So the rounded edge of the trochlea of the humerus fits into the notch or the concave portion of the ulna. In lab, I'll bring models in so we can see how these fit together a little bit better. This is a true hinge joint. Being that it's a hinge joint, the only motions that are possible would be flexion and extension. Sometimes people have a little bit of hyperextension, but a hinge joint, like a door, can only open or close. It's a hinge joint. I think I mentioned I know I did, in the articulations chapter, we talked about a modified hinge joint, which is the knee. That's not the case here. This is a true hinge joint, the humeral ulnar joint, true hinge joint. As such, it can do flexion and extension. All right, cool. Other things to point out, sometimes it's easy to see, you might think that there's rotation happening, but any rotation in this area is coming at the forearm, and that movement is not happening at the elbow, or the rotation is happening at the actual shoulder. So there's literally no rotation possible here, just flexion and extension. Last thing, I'll put it in red just to change things up, the closed pack position of the elbow joint. If we remind ourselves from the articulations chapter, the closed pack position is the position of a joint where there is most bone-on-bone contact. The closed pack position is the position of a joint where there's the most bone-on-bone contact. And when there's the most bone-on-bone contact, it is the most stable position. For the elbow, the closed pack position is full extension. That's when, as this picture is showing us, full extension, that's when there's the most surface area of bone touching each other. It is the strongest position of the elbow, but it's still prone to injury, particularly because we tend to reach our hand out, and let's say you have a wrestler that has his or her hand on the mat and then they get taken down or something. It's not, injury here is more so because of the mechanism. It's not because it's necessarily the weakest position. That was just extra. Just know that the closed pack position of the humeral ulnar joint is full extension. You should be reviewing all these things that I'm talking about, particularly if I write it down. So here we can see some other looks. Actually, this is a good look at the trochlear notch, the end of the ice cream scoop of the ulna, fitting into the trochlea of the humerus, true hinge joint. Here we can see some x-rays, a lateral view. This is the trochlear notch of the ulna. And then the trochlea of the humerus would be that part. And then on the right here, we can see how the trochlear notch of the ulna reaches all the way up. It's really cool. We can also see on this view that the radius is not part of the true elbow joint. So the radius does not contact the humerus. Here's the radius, right? So that's why the true elbow joint is the humero-ulnar joint. All right. Now, that being said, you can see on your notes here, there is something called the humeroradial joint. Let me just skip ahead for 1 minute here. That's the ligaments. Okay. So I'm going to go back for a second. And I'm going to erase this stuff, so feel free to go back in the video to review all those things that you needed to know. Yes. So there can be a moment when there's a humeroradial joint, but it's only at certain range of motion. So if we were going to look at the humeroradial joint, there's only contact between the humerus and the radius at certain ranges of motion tends to be at large degrees of flexion at the humeral ulnar joint. I'm not too worried about this. It is a gliding joint, which means that there's a little bit of motion there. When it says movements allowed, it really just assists motion at the humeral ulnar joint, assists a true elbow joint. So this is not of super importance to us. In most cases, there's no contact between the humerus and the radius, excuse me. In really extreme flexion, there can be a little bit of contact, and it forms what we would classify as a gliding joint. And we're just going to say that any contact or motion there, its function is to assist a true elbow joint, which is the humeral ulnar joint. However, I would like to speak more about the proximal radial ulnar joint. Proximal, and I'm just following in your notes, correct? Proximal radial ulnar joint. And as this suggests, it's the joint between the radius and the ulna. Joint between the radius and the ulna, and it's proximal. So we're talking about the proximal connection. Further distal, close to the wrist, there's a distal radial ulnar joint, but we're saying proximal because we're up close to the elbow. I would like you to know the specific articulating surfaces. So we know it's the radius and ulna, but let's be more specific. It's the articulating surfaces of the head of the radius. And that's how I know the radius, right? The head of the radius is right here. So here's the articulating surface. One side of the head of the radius, put it in yellow, excuse me. And that's going to articulate with the radial notch of the ulna. Why is it called the radial notch? Because it's where the radius fits in. I'll put this in green. The radial notch is a little concave surface there. Cool. All right, what else we got? Let's see. This is our example of a pivot joint. What kind of motion does it do? Pivots. I always think about the Friends episode where they're trying to move a couch through a hallway, and Ross says, pivot, 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 pivot. It pivots to allow, we're going to add to this, pronation and supination. These should already be in your memory bank. Pronation and supination. This is the forearm rotating. What I would like to point out is when we do this motion, it's the radius moving over the ulna. The radius is what is pivoting or moving over the ulna. All right, so just like the other joints, know what the joint is called, what bones it connects. You should know the specific articulating surfaces here, head of the radius and the radial notch of the ulna, what type of joint it is, pivot, and what kind of motion. It pivots to allow for pronation and supination. Lastly, I wanted you to know that it is the radius that is pivoting over the ulna, and the closed pack position. The closed pack position is about 5 degrees of supination. So it's almost with your thumb straight up, kind of in neutral, but it's slight supination. So you don't need to know the 5% specifically, but we can just say slight supination. We are motoring right along. And here we can see a view of that as well. So we have the head of the radius fitting into the radial notch of the ulna, and it is a pivot joint where the radius pivots to allow pronation and supination. Here we can see that as well, a little bit. Maybe it's best over here. I'll do red for the head of the radius, and then yellow for the radial notch of the ulna. And it is the radius that will pivot over the ulna, back and forth. Okay, make sure you review, there's something called the carry angle. Even if you just stand in anatomical position, palms facing forward, usually, instead of your arm just hanging straight down, I'm a terrible drawer, usually the humerus is pretty close to the body, but usually the forearm does come out a little bit. So this angle, boop, boop, is called the carry angle. It's probably the most terrible drawing I've ever done in my life. So let's erase that. But it's showing you that here on the right. So if we look at the humerus, usually remains closer to the body, but then usually the forearm just comes out a little bit. Instead of it being a straight line, the forearm tends to come out a little bit, and that's the angle we're looking at. Typically, the normal traditional carry angle is somewhere between 10 to 15 degrees, where the forearm is angled out laterally. It might be a little bit slightly higher in females compared to males. You know, it's an interesting thing. I don't know that it has a hugely significant function, but it does help us carry things. Well, I'll be. So if you're carrying grocery bags or if you're carrying a tote bag at your side, this will help to allow us to carry something, carry a shopping bag, right? It allows us to carry something a little bit away from the body so it won't hit your leg when you're walking. Okay, so just know the normal angle and what it is. All right, so now we're gonna move on. We've identified the joints here, the major joints in and around the elbow. And now I wanna talk about the supporting structures. Before we get to the ligaments, you can see there that it mentions the joint capsule. We already know that all synovial joints have a joint capsule that encapsulates everything. The ligaments are outside the joint capsule. The joint capsule is there. Here it's in yellow. It's there to contain the fluid that we need to lubricate movement. This picture is a little not the best. They've put the ligaments really close to the joints just to make it easier to see. But if we just look for a moment at the joint capsule, in reality, maybe I'll go back and pardon me. If I go back to this slide, and I'm just going to erase some things as well. If I go back to this slide, maybe I can just draw in the joint capsule without having the distraction of the ligaments. All right, cool. If I was going to draw the joint capsule here, and you can, I don't think I have it, so let me tell you about it. The joint capsule tends to, doesn't tend to, it encapsulates all three joints that we just discussed. So let's just write that down. So here's the joint capsule. We reviewed what it was. It's a way that's it's thicker connective tissue to contain the fluid inside the synovial joint. And what I'm pointing out here is it encloses all three joints. Humeral-ulnar is the big one, humeral-radial only in some ranges of motion, and the proximal radial-ulnar joint. So that's what you need to know. As an aside, it's not the strongest joint capsule, so it tends to be relatively weak. But as we said at the beginning here, we do have strong ligaments around here. So the looseness of this joint capsule is not so much of a bad thing because we have pretty strong ligaments to support it outside of it. Let's talk about those ligaments. Now we're focusing on the humeral-ulnar joint, which is our elbow right now. The humeral-ulnar joint has a radial or lateral collateral ligament and an ulnar or medial collateral ligament. Here's our first introduction to these terms, collateral. We're going to see collateral ligaments in the knee also. Collateral means that these ligaments are on the sides. So collateral means they run along the side of the joint. So here's a straight-on anterior view, letter A, and we can see that the radial collateral ligament runs on the lateral side, or side of the radius, and the ulnar collateral ligament runs on the medial side, or side of the ulna. I think here it's more common to call them ulnar and radial collateral ligaments, whereas in the knee it's more common to call them medial and lateral collateral. But I would like you to know which is which. In anatomical position, the radial is our lateral ligament in anatomical position, and the ulnar is on the medial side. Same side. You probably can't read that very well. The ulnar collateral is our medial ligament, same side as the ulna. So collateral ligaments are on the side, inside and outside. Between these two, the radial collateral ligament is injured less. So on this side, we'll put in green what we want to review about the radial collateral ligament. It's on the outside, lateral side, same side as the radius. Of course, we're talking about ligaments that surround the humeral-ulnar or true elbow joint. This is rarely injured. And it's not because it's any stronger of a ligament necessarily. The bigger reason why it's rarely injured is because it's a rarer mechanism. It's an uncommon mechanism that would injure it. So it's uncommon to have mechanism to injure this. Okay, let me just go ahead for 1 minute. Yeah. Cool. All right. I'm going to introduce something, valgus and varus, and I will go over this again when we meet in person for lecture. But to go, I think this picture might actually be the better picture for me to review this. Lord knows I cannot draw, so let's go with the drawing that we have. So I want to introduce valgus and varus, and I'm hoping some of you have heard this before, maybe if you've had the injury prevention course or something like that. Let's talk about valgus and varus. We're going to start with varus because that's what would injure the radial collateral ligament, varus, versus valgus. These are directions of forces. So we're really talking about a direction of force. It's not necessarily how the intensity of it is, more about the direction of force to an area of the body. And it could be here at the elbow, it could be at the knee. These are the two places that we're going to talk about it the most. So it's more about a direction of force. A varus force is a force from the medial direction. So bear with me here. A varus force is a force from a medial direction. So if we're looking at this picture here, lowercase b, a varus force would be a force on the elbow from the medial side. A force from that direction. Here, it would be a force from this direction. Same thing, a force from the medial side. So imagine, let's just say someone's getting tackled. They have their hand on the ground because they're about to fall, but they're getting tackled. This would mean that the tackler is coming from the medial side, which is kind of impossible. So it's just much less common to have a force from that. A varus force stresses and could injure the lateral collateral ligament. In the elbow, that is the radial collateral ligament. So it could stress that and lead to injury. Right? If we have a force from the medial side, it could potentially stress this lateral ligament. You might get a bruise on the medial side. So if I had to get tackled from the medial side, I might get a bruise here, but it's going to stretch. It's going to stress and stretch. It stretches that lateral collateral ligament. I'm going to show you on a model in class, but if you can just memorize this to start, it'll make your life a lot easier. So it means that the valgus is just the opposite. A valgus is a force from the lateral direction. Force from, and the way that I remember this is that the word valgus has an L in it. I think L for lateral. And then the other one is just the other one. Sometimes you only have to memorize one. If valgus is a force from a lateral direction or outside, then varus is the other. This is going to stretch the medial collateral ligaments, which at the elbow is the ulnar collateral. And this is much more common because it's much more common to have a force from the lateral. So in this direction, we would have a force from this way. Isn't it easier? Isn't it a much more common mechanism to get tackled from the outside? And that's going to stretch the medial collateral ligament. And it turns out, folks, these are the same things with the knee. It's much more common to injure your medial collateral ligament, mostly because it's just much more common to have a valgus force to get tackled from the outside. So make sure that you review that. Please, please, please. So if I go back to the ligaments, if I was going to have an injury to the radial collateral ligament, it would be injured from a varus force. So it's uncommon, but if it is injured, it's going to be from a varus force. Okay. Let's look at the ulnar collateral ligament. If you've heard of the Tommy John surgery in baseball pitchers, this is the one that's being repaired, UCL, ulnar collateral ligament. Here I have it in yellow. It's on the medial side, right? Medial side. Let's look at the structure of it. The lateral collateral ligament, the radial collateral ligament has more of just one band. Let me add that, right? The radial collateral ligament has just kind of a single band that makes it up. Or fewer bands. Here it kind of looks like 2, but it's got fewer, right? And put 1 to 2, but fewer bands. The ulnar collateral ligament is formed by 3 separate bands, so it's a larger ligament. Anterior, posterior, and transverse. Anterior, posterior, and transverse. Here they are. So we're on the medial side of the elbow, ulnar collateral ligament, same side as the ulna. We have an anterior bundle, a posterior bundle, and a transverse. Please be able to list these. Anterior, posterior, transverse. You should know which is the strongest. Hold on, my cat is... Hey! Get out! Hold on one second. My cat's scratching the hell out of my couch. Hold on. These videos are always interrupted by the cats getting into trouble. I apologize for the interruption. Okay, the strongest of these is the anterior. The strongest of these is the anterior. This is the one that really tends to be injured in those baseball pitchers. The transverse tends to be more of a connector. We can talk about more about this, but I would just like you to know that the ulnar collateral, it's on the medial side. It's got 3 bands, so it's bigger than the radial. The strongest of these bands is the anterior, but be able to list all of them. Anterior, posterior, transverse. All right. This is a much more common injury, commonly injured, and the injury would occur due to a valgus force. All right. We're going to talk more about this later this chapter. All right, there is one more ligament that I would like to point out, and that is the annular ligament. Let's see, do I have a picture of the annular ligament? I do here. Let me get a new color. Orange. The last ligament here is going to go over the proximal portion of the radius and ulna. It's called the annular ligament. This runs over the head of the radius. Annular ligament runs over the head of the radius. It basically holds the head of the radius in place. Remember, it is the radius that rotates and pivots. Isn't it the radius that pivots? So we don't want it to be just unstable and just, kind of willy-nilly. So because we have movement here at the proximal radial ulnar joint, we need to make sure that we keep that head of the radius stable. So the annular ligament just runs from one side of the radius to the other. Excuse me, one side of the ulna to the other. It runs from one side of the ulna to the other, holds head of the radius in place as the radius pivots during supination and pronation. Holds the head of the radius in place as the radius pivots during pronation and supination. Okay, a couple of other anatomical things to review. We have the interosseous membrane. So there's a connective tissue membrane that connects the radius and ulna a little further down. Kind of just holds these bones together a little. Just know that exists. And then lastly, I do want to mention this ulnar nerve. The ulnar nerve, check it out. It's on the medial side of the elbow. So let's locate this anatomically. Medial side of elbow. It runs between the medial epicondyle of the humerus. We're going to be palpating these in lab. It runs between the medial epicondyle of the humerus and the olecranon process of the ulna, which is the tip of your elbow. Runs between the medial epicondyle of humerus and olecranon process. Here's the olecranon process. Here's the medial epicondyle. Yellow nerve runs right between on the medial side of the elbow. If you've heard of your funny bone, quote unquote, if you hit the inside of your elbow, the medial side just right, you might hit this, and that's why you get the numbness or tingling. Also, why I bring this up, what if someone tears their ulnar collateral ligament? Excuse me. The surgery for that is tricky. Any surgery is tricky, but one particular thing that makes this area difficult to deal with is the ulnar nerve. A lot of times they'll do what's called an ulnar nerve transposition, where the surgeons will actually kind of move the ulnar nerve out of the way so they can get in there and repair the ligament. It just makes things more tricky. All right. So my goal for this first part of the video, for this first lecture here, is I want to get through most of the anatomy. So I do want to move down towards the wrist and hand. And we'll talk a little bit about these joints, and then we'll leave the rest for our next in-person lecture. Okay, so now we're switching gears to the wrist. Let's just say right off the bat, it's really complicated, right? We have 8 carpal bones, 8 small bones connecting with each other. And then we have some of those same carpal bones connecting with the radius and ulna. So it is complex. It's not quite as simple as the elbow, where it's just the humerus and the ulna and it forms a hinge. That's kind of simplistic, isn't it? Here we have so many bones, so many moving parts, and some of that movement is really hard to quantify, but all the tiny movement in each part works together to form this complex arrangement. But I do want to talk about some joints. So if we're just following in our notes here, the first one we're going to talk about is the radiocarpal joint. Radiocarpal. So joint number 1, radiocarpal. Joint between the radius and some of the carpals. But we're not just going to leave it at that, folks. We've got to be more specific. So before we finish this discussion or continue with it, we need to make sure that you know these carpal bones. There are 8 of them. Make sure you review. I've given you the way that I've always memorized them. One of the sayings is, some lovers try positions that they can't handle. Ha ha ha. For this to work, you would start on the thumb side. So if we look at number 1 here, right? We're naming these carpal bones starting at thumb side and starting at the proximal row. The first row more proximal. So using that thumb side, the first one, number 1, scaphoid, lunate, triquetrum, pisiform. So the first 4 are the proximal row, and then we switch to the distal row. That they can't handle. So we go back to the thumb side again. Trapezium, trapezoid, capitate, hamate. I am going to ask you questions about these bones. This is memorization. So whatever you need to do to be able to memorize, I will ask you questions about these. Scaphoid, lunate, triquetrum, pisiform. Come back to the thumb side, but now we're in the distal row. Trapezium, trapezoid, capitate, hamate. Right? Scaphoid, oh, let me do a different color. As I said in lab last week, I was in your position, and it's finding what way to memorize works best for you. Scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. Okay. So study, memorize. When we go back to the radiocarpal joint, now we can be more specific. Let me just go ahead for one moment. I've had them labeled here as well. Okay. Radiocarpal joint. It is a joint between the radius and now we can list the carpals. Scaphoid, lunate, triquetrum. Some lovers try. The first 3 bones. I'm just going to write first 3 bones because you're going to memorize them. Scaphoid, lunate, triquetrum. Some lovers try. If you look at the picture, we can see. Here we have the radius, scaphoid, lunate, and because the triquetrum is attached to it, that counts also. This is a condyloid joint, which is like a mini ball and socket. Condyloid joint. What motions are possible? Flexion, extension, circumduction, and this is where we get radial and ulnar deviation. The reason why we're talking about this one is because it's responsible for a lot of motion. This is where we have radial and ulnar deviation. Radiocarpal joint. Radius in the first 3 carpals, scaphoid, lunate, triquetrum, condyloid, flexion extension, circumduction, and radial ulnar deviation. While we're down here, let's just talk for a moment about the distal radio-ulnar joint. I'm going to do that in green. We just talked about the proximal radio-ulnar joint. That was where the radius and ulna attach proximally, close to the elbow. but there's also a distal radio ulnar joint. We're going to keep this real simple. It's the joint between the distal radius and ulna, and there's not much movement at all. It exists, those bones do touch the distal radius and ulna, but there's not a whole lot of movement here. So know that it's there, distal radio-ulnar joint, where the distal radius and ulna connect, but not much motion at all. The last joint of the wrist, before we get to the hand, so we're not talking about the hand yet. I'm going to save that for our meeting in person. The last of the wrist, we talked about the radiocarpal joint. That's a big one. And then we'd mentioned that the radius and ulna do touch distally, but not much motion. The last one I want to talk about would be the intercarpal joints. Let's use a different color. So this is our third one, I guess, because our second one was the green, right? Trying to be consistent here. It's not working out so well for me today now, is it? The second one we mentioned was the distal radio-ulnar joint, and the third one we're mentioning would be the intercarpal joints. And I think I may have a typo. It is on my notes. I forgot the second R, intercarpal. So we don't really need to say much because it's the joint between the carpals. It's the joints between the remaining carpals. So each of these carpal bones touch with another one. So it's just a joint formed between individual carpal bones. Joints between individual carpal bones. Intercarpal, between the carpal bones. These are gliding joints. Not much motion, but they do small gliding. And together, it assists the radiocarpal joint. So there's some small gliding motion, and there's more between some of the carpals versus the other. And they help overall with the overall wrist function. We can keep it that simple. Help with the overall wrist motion. Small gliding motions that help with the overall wrist function. All right. So to end this video, I want to get through letter D, supporting structures, and then we'll start with the hand when we meet in person on Thursday. So we've identified these important joints of the wrist, and there's just a couple supporting structures that we're going to talk about. One of them is a cartilaginous disc. We've talked about other pieces of cartilage. We talked about the labrum in the shoulder. We will talk about the menisci in the knee. Well, here's another case where we have an additional piece of cartilage. It is called the TFCC, Triangular Fibrocartilage Complex. Let's locate where we are. Let's see. I can use, there's red, and then we can use maybe yellow would be good. We are looking at this disc right here. So it is between the ulna. So now we're on the ulnar side. It is between the ulna and, more specifically, the lunate. Some lovers try positions. Lunate, the second one. So here's the lunate. Oh, let me do it in yellow. Here's the lunate, and here's the ulna. It's between the triquetrum a little bit, but it's more between the lunate and the ulna. It is a piece of cartilage. When it magnifies here on the right, I think it does a pretty good job. I'm going to fill in and I'm going to outline in yellow this little disc. Why is it called the triangular fibrocartilage complex? Because it's kind of triangular, right? It kind of runs like this. I mean, not really triangular, but you get my point, right? So it's kind of cool. We just have this, oh, I meant to get the eraser. We have this little, it's almost like a wedge of cartilage. It's almost like one of those door stops. You know those rubber door stops you put on the ground? That's kind of the shape it reminds me of. So I think that word actually is pretty helpful here. It's a wedge of cartilage. You can imagine that we get a lot of force, a lot of load coming over here, especially during ulnar deviation. So its primary role is shock absorption. This just happens to be an area where there's a lot of load, bone versus bone. So because there's just a lot of force, bone versus bone here, the body has put in here a protective wedge of fibrocartilage. In your notes, I think it just says cartilaginous disc. I would like you to know that it's called this fibrocartilage complex. Be able to identify that in a multiple choice question. But then also know that it's between the ulna and the lunate. Shock absorption. You'll be happy to know there are a lot. There's a crap ton of ligaments. In the intercarpal joints, I've listed some specific ligaments there, but you don't have to know them. You don't need to know the volar, radiocarpal, or down here, radial or ulnar collateral. I did ask you to know the radial or ulnar collateral the radial and ulnar collateral up by the elbow. I did ask you to know that, but not down here. I put this picture in here just so you can see that there are ligaments running between the carpals. There's ligaments every which way, right? So of course they're connected. All right, the last thing I would like to point out, last thing for this video here, is the flexor retinaculum. It's kind of a fun word. A retinaculum is a thick band of connective tissue. I mean, we have connective tissue pretty much everywhere, but a retinaculum is a thick band. So the key word here is thick. The retinaculum tends to, and this is just a everyday definition, so I apologize for its simplicity, holds things in. In this case, the flexor retinaculum is on the palm or anterior side of the wrist. And what is it holding in? It's holding underneath it all of those forearm flexor muscles. We're going to review muscles in lab. So we have the flexor carpi radialis, flexor carpi ulnaris, flexor digitorum longus. These are all the muscles in our anterior forearm. But those muscles come down and their tendons here are those tendons. We have a bunch of tendons. So this flexor retinaculum that I'm going to color in green, see this thick band of connective tissue? It holds in those flexor muscle tendons. Underneath is the carpal tunnel. So this forms the carpal tunnel. Underneath is carpal tunnel. We're in the area of the carpals. That tunnel is the space through which those tendons pass. The tunnel is the space through which those tendons pass. So in that carpal tunnel, the carpal tunnel space for passage of not only tendons, so the carpal tunnel, we're still on the palm side in the wrist, the space that underneath the flexor retinaculum, the space for passage of these flexor tendons, but also nerves and blood vessels. Last thing here that I'd like you to know, there's one muscle tendon that is not in the carpal tunnel, palmaris longus. The only tendon that is superficial to the carpal tunnel. Meaning it doesn't pass through the carpal tunnel. Only tendon. All the other ones run underneath the flexor retinaculum in the carpal tunnel. The only muscle tendon here that is superficial, you can, in this picture, it kind of blends in with the flexor retinaculum, but the point is, it doesn't go underneath it. Palmaris longus. All right, we're going to pick up where we left off in person, talking about the hand, and then we'll do our kinetic analysis and injuries. Happy studying. I'm always here if you have questions.